Hello. Follow our videos and recommend us to others. Atorvastatin drug group. Lipid-lowering drugs. Atorvastatin is an HMG-CoA reductase inhibitor or statin. Atorvastatin reduces bad blood cholesterol or LDL and triglycerides while increasing good blood cholesterol or HDL and is used in the treatment of high blood cholesterol. Atorvastatin is used to treat high cholesterol and reduce the risk of stroke, heart attack, or other heart complications in people with type 2 diabetes, coronary heart disease, or other risk factors. Atorvastatin should not be used if you are pregnant, breastfeeding, or suffering from liver disease. Serious drug interactions can occur if certain drugs are used together with atorvastatin. Therefore, you should inform your doctor or pharmacist about your medications. In rare cases, atorvastatin can cause conditions that lead to the breakdown of skeletal muscle tissue, potentially leading to kidney failure. Call your doctor immediately if you have muscle pain, tenderness, or weakness, especially if you have a fever, unusual fatigue, or dark-colored urine. Atorvastatin mechanism of action. Atorvastatin is a statin drug and a competitive inhibitor of HMG-CoA, 3-hydroxy-3-methylglutaryl coenzyme A, reductase, which catalyzes the conversion of HMG-CoA to mevalonate, the primary rate-limiting step in cholesterol biosynthesis. Atorvastatin acts primarily in the liver, where lowering hepatic cholesterol concentration stimulates the upregulation of hepatic low-density lipoprotein (LDL) receptors, which increases hepatic uptake of LDL. Atorvastatin also reduces very low-density lipoprotein cholesterol (VLDLC), serum triglycerides (TG), and intermediate density lipoprotein (IDL), as well as the number of apolipoprotein B, ApoB, containing particles, but lipoprotein increases high-density cholesterol (HDLC). Pharmacodynamics. Atorvastatin is an oral lipid-lowering agent that reversibly inhibits HMG-CoA reductase. This medicine reduces the plasma concentration of total cholesterol, low-density lipoprotein cholesterol (LDLC), apolipoprotein B, ApoB, and triglyceride (TG), and increases the plasma concentration of high-density lipoprotein cholesterol (HDLC). High LDLC, low HDLC, and high TG concentrations in plasma are associated with an increased risk of arteriosclerosis and cardiovascular diseases. The ratio of total cholesterol to HDLC is a strong predictor of coronary artery disease, and higher ratios are associated with a higher risk of disease. By lowering LDLC and TG and increasing HDLC, atorvastatin reduces the risk of cardiovascular disease and mortality. Elevated cholesterol levels, and especially high levels of low-density lipoprotein (LDL), are an important risk factor for developing CVD or cardiovascular disease. Clinical studies have shown that atorvastatin lowers LDL-C in total cholesterol by 36 to 53%. In patients with dysbeta-lipoproteinemia, atorvastatin reduces the level of medium-density lipoprotein cholesterol. It has also been suggested that atorvastatin can limit angiogenesis, which can be useful in the treatment of chronic subdural hematoma, myopathy, rhabdomyolysis. Atorvastatin, like other HMG-CoA reductase inhibitors, is associated with a risk of drug-induced myopathy with muscle pain, tenderness, or weakness associated with elevated creatine kinase (CK) levels. Myopathy often presents as rhabdomyolysis with or without acute renal failure secondary to myoglobinuria. The risk of statin-induced myopathy is dose-related, and symptoms of myopathy usually resolve with drug discontinuation. Results from observational studies suggest that 10 to 15% of people taking statins may experience muscle pain at some point. Liver dysfunction. Statins, like some other lipid-lowering therapies, have been associated with biochemical abnormalities of liver function. Persistent elevations, greater than 3 times the upper limit of normal, in serum transaminases occurred in 0.7% of patients who received atorvastatin in clinical trials. This effect appears to be dose-related. Endocrine effects. Statins are associated with the risk of increased serum HbA1c and glucose levels. An in vitro study showed a dose-dependent cytotoxic effect on human pancreatic islet beta cells after treatment with atorvastatin. In addition, the amount of insulin secretion decreased compared to the control group. HMG-CoA reductase inhibitors interfere with cholesterol synthesis and may theoretically interfere with adrenal or gonadal steroid production. Clinical studies using atorvastatin and other HMG-CoA reductase inhibitors have shown that these agents do not affect plasma cortisol concentrations, plasma basal testosterone concentrations, or adrenal reserve. However, the effect of statins on male fertility has not been fully investigated. The effects of statins on the pituitary gonadal axis in postmenopausal women are unknown. Pharmacokinetics. Absorption. This drug is quickly absorbed from the digestive tract after oral intake. The maximum plasma concentration is reached within 1 to 2 hours. The absolute bioavailability of the drug is about 14%. Binding to protein. Binding of the drug to protein is very high, about 98%. Metabolism. This drug is mainly metabolized to the active metabolite, which is responsible for 70% of the inhibitory effect of HMG-CoA reductase. After hepatic and extrahepatic metabolism, it is mainly excreted through bile, and less than 2% is excreted through urine. Elimination route. Atorvastatin and its metabolites mainly they are eliminated in the bile without enterohepatic recirculation. Renal elimination of atorvastatin is very low and represents less than 1% of the eliminated dose. Elimination half-life. The half-life of atorvastatin is 14 hours, while the half-life of the active metabolite is 30 hours. Uses of atorvastatin. 1. Hyperlipidemia. a lot of blood fat. Primary hypercholesterolemia and mixed lipid disorders, hypertriglyceridemia, high blood triglycerides, primary dysbeta-lipoproteinemia, homozygous familial hypercholesterolemia, heterozygous familial hypercholesterolemia. 2. Prevention of cardiovascular diseases. Dosage of atorvastatin. Note: when choosing the start of treatment and choosing the intensity of the dose, consider the following: age, LDL cholesterol levels, history of atherosclerotic cardiovascular disease, ASCVD, risk factors, possible side effects, and drug interactions. High-intensity statin therapy, atorvastatin 40 to 80 mg per day, generally lowers LDL-C by 50%. Moderate-intensity statin therapy, atorvastatin 10 to 20 mg per day, generally lowers LDL-C by 30% to 49%. Assess response to therapy 1 to 3 months after initiation of therapy or dose adjustment and every 3 to 12 months thereafter. Heterozygous familial hypercholesterolemia, high-intensity treatment, oral. Initial, 40 or 80 mg once daily. If 40 mg once a day is started and tolerated, increase to 80 mg once a day. Homozygous familial hypercholesterolemia, high-intensity treatment, oral. 80 mg once a day. Prevention of cardiovascular diseases. Adults, 10 to 80 mg once a day. Hypertriglyceridemia, along with diet to increase TG level. Initially 10 mg orally daily. Maintenance 10 to 80 mg orally daily after starting or titrating the dose. Check the lipid level after 2 to 4 weeks and adjust the dose accordingly. Primary dysbeta-lipoproteinemia, Fredrickson type 3, in a patient with inadequate response to diet. Maintenance, 10 to 80 mg orally daily after starting or titrating the dose. Check the lipid level after 2 to 4 weeks and adjust the dose accordingly. Prohibited usage. Hypersensitivity to atorvastatin, active liver disease, or unexplained transaminase elevations. Pregnancy. Breastfeeding. Side effects of atorvastatin. Common side effects, over 10%, diarrhea, 5 to 14%. Nasopharyngitis, 4 to 13%. Arthralgia, 4 to 12%. Less frequent side effects, 1% to 10%. Insomnia, 1 to 5%. Urinary tract infection, 4 to 8%. Nausea, 4 to 7%. Indigestion, 3 to 6%. Increased transaminases, 2 to 3%. Muscle spasms, 2 to 5%. Musculoskeletal pain, 2 to 5%. Myalgia, 3 to 8%. Limb pain, 3 to 8%. Sore throat, 1 to 4%. Drug interactions. Keto abemetapir may increase serum concentrations of CYP3A4 substrates, high risk with inhibitors. Category X interaction. Contraindication to simultaneous use. Combination of anti-hepatitis C virus products may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use of sanapravir may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use bezafibrate may increase the myopathic rhabdomyolysis effect of HMG-CoA reductase inhibitors, statins. Bezafibrate may increase the serum concentration of HMG-CoA reductase inhibitors, statins. In particular, bezafibrate may increase the serum concentration of fluvastatin. Category D interference. Treatment modification. Ciprofibrate This may increase the adverse or toxic effect of HMG-CoA reductase inhibitors, statins. Management. Avoid concomitant use of HMG-CoA reductase inhibitors and ciprofibrate. If concomitant therapy is considered, the benefits should be carefully weighed against the risks, and patients should be closely monitored for signs of myotoxicity. Category D interference. Treatment modification. Clarithromycin may increase the serum concentration of atorvastatin. Management. Limit atorvastatin to a maximum dose of 20 mg per day. For adults, when used with clarithromycin, monitor patients more closely for atorvastatin toxicity if this combination is used. Category D interference. Treatment modification. Cobicistat may increase the serum concentration of atorvastatin. Management. Avoid co-administration of atorvastatin with atazanavir or cobicistat. The dose of atorvastatin when combined with other regimens containing cobicistat should not exceed 20 mg per day. Category D interference. Treatment modification. Conavapan may increase the serum concentration of CYP3A4 substrate, high risk with inhibitors. Category X interaction. Contraindication to simultaneous use. Cyclosporine, systemic, may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use. CYP3A4 induces, strong, may increase CYP3A4 substrate metabolism, high risk with induces. Category D interference. Treatment modification. CYP3A4 inhibitors, strong, may decrease CYP3A4 substrate metabolism, high risk with inhibitors. Category D interference. Treatment modification. Cyproterone may increase the serum concentration of HMG-CoA reductase inhibitors, statins. Management. Avoid statins metabolized by CYP3A4, e.g. simvastatin, and avoid fluvastatin in patients receiving high doses of cyproterone, 300 mg per day. If you need statin therapy, consider using pravastatin, rosuvastatin, or pitavastatin. Category D interference. Treatment modification. Dabrafenib may decrease serum concentrations of CYP3A4 substrates, with a high risk of induction. Category D interference. Treatment modification. Daptomycin, possible HMG-CoA reductase inhibitors. Statins increase the harmful or daptomycin's harmful or toxic effect, and the risk of musculoskeletal toxicity may be increased. Management. Consider temporarily discontinuing HMG-CoA reductase therapy before daptomycin. If used together, regular, i.e., at least weekly, monitoring of CPK concentrations is recommended. Category D interference. Treatment modification. Diltiazem, atorvastatin may increase the serum concentration of diltiazem. Diltiazem may increase the serum concentration of atorvastatin. Management. Consider using low-dose atorvastatin with diltiazem. Category D interference. Treatment modification. Elbavir may increase the serum concentration of atorvastatin. Management. Limit the dose of atorvastatin to a maximum of 20 mg per day when used with elbavir and grazoprevir. Monitor closely for evidence of statin-related toxicities such as myalgia or myopathy. Category D interference. Treatment modification. Enzalutamide may decrease serum concentrations of CYP3A4 substrates, with a high risk of induction. Management. Concomitant use of enzalutamide with CYP3A4 substrates that have a narrow therapeutic window should be avoided. Enzalutamide and other CYP3A4 substrates should be used with caution and close monitoring. Category D interference. Treatment modification. Phosphonitoin. Phenytoin may decrease the serum concentration of HMG-CoA reductase inhibitors, statins. Management. Avoid concomitant use of phosphonitoin, phenytoin and statins. If combined, monitor the therapeutic effects of statins when starting phosphonitoin or phenytoin or increasing the dose. Category D interference. Treatment modification. Fosmesivir may increase the serum concentration of HMG-CoA reductase inhibitors, statins. Management. Use the lowest starting statin dose and monitor patients closely for statin-related adverse events, e.g. muscle pain, when co-administered with fostemavir. Category D interference. Treatment modification. Fusidic acid, systemic, may increase the adverse and toxic effects of HMG-CoA reductase inhibitors, statins. In particular, the risk of myotoxicity, including rhabdomyolysis, may be significantly increased. Management. Avoid concurrent use as much as possible. Its use is prohibited in several countries in the Summary of Product Characteristics. Category X interaction. Contraindication to simultaneous use. Fusidic acid, systemic, may increase serum concentrations of CYP3A4 substrates, high risk with inhibitors. Category X interaction. Contraindication to simultaneous use. Gemfibrozil may increase the myopathic, rhabdomyolysis, effect of atorvastatin. Gemfibrozil may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use. Glecaprevir and pebrentisvir may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use. Grapefruit juice may increase the serum concentration of HMG-CoA reductase inhibitors, statins. Management. Avoid taking grapefruit juice with lovastatin or simvastatin at the same time. Avoid large amounts of grapefruit juice with atorvastatin. Category D interference. Treatment modification. Grazoprevir may increase the serum concentration of atorvastatin. Management. Limit the dose of atorvastatin to a maximum of 20 mg per day when used with elbavir and grazoprevir. Monitor closely for evidence of statin-related toxicities such as myalgia or myopathy. Category D interference. Treatment modification. Adalimumab may increase serum concentrations of CYP3A4 substrates, high risk with inhibitors. Category X interaction. Contraindication to simultaneous use. Itraconazole may increase the serum concentration of atorvastatin. Management. In patients receiving itraconazole, limit atorvastatin to a maximum dose of 20 mg per day. Assess clinical response to ensure that the lowest necessary dose of atorvastatin is used. Consider using fluvastatin, rosuvastatin, atorvastatin, or pravastatin if possible. Category D interference. Treatment modification. Ketoconazole, systemic. Atorvastatin may increase the adverse or toxic effects of ketoconazole, systemic. Ketoconazole, systemic, may increase the serum concentration of atorvastatin. Management. Administer ketoconazole with atorvastatin cautiously and monitor for toxic effects of atorvastatin, e.g. myalgia, rhabdomyolysis, changes in liver function tests. Consider using fluvastatin, rosuvastatin, pitavastatin, or pravastatin if possible. Category D interference. Treatment modification. Lanthanum, HMG-CoA reductase inhibitors, statins, may decrease serum concentrations of lanthanum. Administration. Administer HMG-CoA reductase inhibitors at least 2 hours before or after lanthanum. Risk D. Consider treatment modification. Letermovir may increase the serum concentration of atorvastatin. Management. Reduce the dose of atorvastatin to 20 mg per day when combined with letermovir. Atorvastatin, at any dose, is not recommended if letermovir is used concurrently with cyclosporine. Category D interference. Treatment modification. Lomitapide may increase the serum concentration of atorvastatin. Atorvastatin may increase the serum concentration of lomitapide. Management. When the lomitapide dose is 10 mg per day or more, reduce the lomitapide dose by 50% when combined with atorvastatin. No dosage adjustment is necessary when the lomitapide dose is 5 mg per day. Category D interference. Treatment modification. Lonafarnib may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use. Mifepriston may increase serum concentrations of CYP3A4 substrates, high risk with inhibitors. Management. Minimize doses of CYP3A4 substrates and monitor for increased concentrations or toxicity during and 2 weeks after treatment with mifepriston. Avoid cyclosporine, dihydroergotamine, ergotamine, fentanyl, pimozide, quinidine, sirolimus, and tacrolimus. Category D interference. Treatment modification. Myototan may decrease serum concentrations of CYP3A4 substrates, with a high risk of induction. Management. Doses of CYP3A4 substrates should be adjusted significantly when used in patients treated with mitotan. Category D interference. Treatment modification. Posaconazole may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use. Protease inhibitors may increase the serum concentration of atorvastatin. Management. Use the lowest dose of atorvastatin and monitor closely. Dose restriction of atorvastatin is required for use with many protease inhibitors. For more details, see the drug interaction monograph. Avoid atorvastatin with tipranavir or ritonavir and atazanavir or cobicistat. Category D interference. Treatment modification. Rifampin may increase the serum concentration of atorvastatin. Rifampin may decrease the serum concentration of atorvastatin. Management. If using both drugs, use atorvastatin and rifampin at the same time. Monitor the response to atorvastatin closely. Category D interference. Treatment modification. Simavir may increase the serum concentration of atorvastatin. Management. The maximum dose of atorvastatin with the simultaneous use of simpravir should not be more than 40 mg per day, and the use of the lowest dose of atorvastatin necessary is recommended. Monitoring the toxicity of atorvastatin with co-administration. Risk D. Modification of treatment. Calendula, THERB, may increase the metabolism of HMG-CoA reductase inhibitors, statins. Management. Consider avoiding the co-administration of this drug with HMG-CoA reductase inhibitors to avoid possible reduction of lipid-lowering effects. Monitor for decreased effects during concomitant therapy. Category D interference. Treatment modification. Stiripentol may increase the serum concentration of CYP3A4 substrates, high risk with inhibitors. Management. The use of stiripentol with CYP3A4 substrates that have a narrow therapeutic window should be avoided due to the increased risk of adverse effects and toxicity. Any CYP3A4 substrate used with stiripentol requires close monitoring. Category D interference. Treatment modification. Telithromycin may increase the serum concentration of atorvastatin. Management. Limit atorvastatin to a maximum dose of 20 mg per day when used concurrently with telithromycin. Although not a specific recommendation in labeling atorvastatin, this is consistent with the dosing of other strong CYP3A4 inhibitors, including clarithromycin. Category D interference. Treatment modification. Tipranavir may increase the serum concentration of atorvastatin. Category X interaction. Contraindication to simultaneous use. Verapamil. Atorvastatin may increase the serum concentration of verapamil. Verapamil may increase the serum concentration of atorvastatin. Management. Consider using low-dose atorvastatin with verapamil. Category D interference. Treatment modification. Voriconazole may increase the serum concentration of atorvastatin. Management. Monitor for toxic effects of atorvastatin, e.g., myalgia, rhabdomyolysis. Changes in liver function tests during concomitant therapy and reduce the dose of atorvastatin if possible. Consider using fluvastatin, rosuvastatin, pitavastatin, or pravastatin if possible. Category D interference. Treatment modification. Varxilapravir may increase the serum concentration of atorvastatin. Category D interference. Treatment modification. Warnings. 1. Rhabdomyolysis with or without acute kidney failure secondary to myoglobinuria has been reported. 2. Atorvastatin may cause myopathy characterized by muscle pain and weakness with creatine kinase, CK, above 10 times the normal range. Myopathy risk factors include age 65 years or older, uncontrolled hypothyroidism, renal impairment, concomitant use of certain medications, and high doses. 3. Adjusting the dose of atorvastatin is recommended for patients who use antiviral, antifungal, azole, or macrolide antibiotic drugs. 4. The treatment should be stopped for any patient suffering from myopathy, renal failure, or an increase in transaminase level to 3 times the normal limit. Recommended tips: avoid using atorvastatin in cases of allergy to this drug, during pregnancy or breastfeeding, or if you have kidney problems. To ensure the safe use of this medicine, if you have any of the following symptoms, be sure to inform your doctor. History of liver disease, history of kidney disease, muscle pain or weakness, thyroid disorders, drinking more than 2 bottles of alcohol per day, avoid eating foods that are high in fat or cholesterol. Atorvastatin will not be effective in lowering cholesterol if you do not follow a cholesterol-lowering diet. Use in pregnancy. Use during pregnancy is prohibited. Contraindications for use in pregnant women. Because safety in pregnant women has not been proven and there is no benefit to using fat-reducing drugs during pregnancy. Since HMG-CoA reductase inhibitors reduce the synthesis of cholesterol and possibly the synthesis of other biologically active substances from cholesterol, the treatment may cause harm to the fetus if administered to a pregnant woman. Treatment should be stopped as soon as pregnancy is detected. Use in breastfeeding. Use during breastfeeding is contraindicated. Similar drugs: simvastatin, lovastatin, Rosovas, Latin pitavastatin, pravastatin, fluvastatin. Please consult your doctor before taking the medicine. Follow our videos and introduce us to others. Don't forget to like and comment. Thank you for watching my video.